Good afternoon. If everyone could take their seats, I'd appreciate it. It gives me great pleasure to introduce our guests for the day. And this is on behalf of the Bill and Melinda Gates Institute for Population and Reproductive Health and the Center for Global Health. We welcome, and again, as I said, it's a great pleasure to introduce His Excellency Dr.Kesetebirhan Admasu, who is the Minister of Health of Ethiopia. And to give you just a little bit of a background, his background, I'm going to take a couple minutes so we're all in the same frame and know of his interests and his background. So His Excellency became Minister of Health of the Federal Democratic Republic of Ethiopia in November of the past year, 2012. But prior to that appointment, he served as State Minister of Health Programs from October 2010 to 2012 and Director General of Health Promotion and Disease Prevention beginning in October of 2009. In his capacity as the Director General, Dr. Kesetebirhan Admasu oversaw the reform of the health sector in Ethiopia and led the national implementation of the flagship health extension program, which you see on the screen. He's been a champion of innovation, task shifting, and implementation to scale. Absolutely critical issues as we look forward to health service delivery in Ethiopia. During his tenure as Director General, he also led the rollout of an integrated community case management of childhood illnesses and delivery of the single-rod contraceptive implant through the health extension program. This health extension program, which is abbreviated HEP, is an innovative health service delivery program that aims at universal coverage of primary health care. The program gives priority to the prevention and control of communicable diseases with active community participation, aimed at providing equitable access to health services, something we could all learn a great deal about. The government aims to train 30,000 health extension workers and deploy them to 15,000 villages. In addition, thousands of other healthcare services staff, particularly at the health center level, will receive training to aid in the accelerated implementation of this program. Currently, there's 34 training centers in 7 regions training these HEW workers. Dr. Admasu has dedicated his entire career to public service and scientific research focused on major public health problems in Ethiopia. Recently, the minister joined U.S. aid leadership to encourage all African health ministers to adopt a health scorecard to better monitor health needs and gains. A medical doctor by training with a master's degree in public health, he has served in a number of clinical and public health positions. He's worked as public-private partnership team leader, CEO of a tertiary hospital, Director General and State Minister before assuming his current ministerial portfolio. So in summary, it is a pleasure to welcome you to Johns Hopkins University. I hope you have time to see some of the School of Public Health, the hospital, and I know your afternoon's quite busy going to CCP and to JPIGO as well. And I look forward to seeing you a little bit later on in the evening as well. But for all of the faculty and students of Johns Hopkins School of Public Health, we welcome you. Thank you.
Thank you very much. Good afternoon. I would like to thank Amy for extending the invitation to share with you the health extension program. It's our flagship program, and it is the pillar of our health system. So I'm really delighted to share what we are doing in terms of expanding access to basic services in rural parts of Ethiopia. I presume some of you might know Ethiopia. Ethiopia is located in the Horn of Africa. We have an ancient civilization. We are the second most populous country in Africa with an estimated population of 83 million. And the population growth rate is 2.4%. So you could say that every year we create a new African country in Ethiopia with the majority of the people lives in rural areas, and the total fertility rate has been declining over the last 2 decades from what used to be 6.4 in 1990 to 4.8 in 2010. Our contraceptive prevalence rate has increased to nearly 29% in 2010, and the unmet need for family planning has been 25%. So how come we come up with the health extension program? Ethiopia has what we call a health sector development program, and this is, a 5 years strategic plan for the health sector. And during the review of the first HSDP in 2002, we realized that we haven't really created access to basic health services, and we haven't expanded health facilities, and we had fundamental gap in applying the core principles that were outlined in the health policy, because the majority of our people lives in rural areas, and in 2002, most of our health facilities were concentrated in urban areas, and we relied heavily on outreach services to the rural community, and it hasn't worked out very well. So although we set ambitious targets during HSDP1, at the end of the strategic plan, we didn't meet most of the targets. And that was because the program and the service delivery heavily relied on the health facilities that were concentrated in urban areas. So as a government and as a Ministry of Health, this has led to serious discussions, deliberations with a wide range of stakeholders, and it has led to the development of the health extension program. The health extension program, we believe, is a significantly different, and it's a fundamental departure from the classic health service delivery model, where there is an interaction between a clinician who is based in a health facility and a patient that passively comes to the facility. So we, as a government, needed a mechanism where we transfer responsibility to individual households. And unless you make families and individual households responsible and have the necessary knowledge and skill to have control over their health, it would be difficult to really have an impact within a short period of time. So the health extension program is a vehicle to transfer that responsibility to individual households. So when the program was designed, a number of activities had been outlined, and it has to be completed. We needed to train and deploy health extension workers. These community health extension workers, they are new cadres to the system. So we needed schools that would train these health extension workers. they need a base where they can keep some of their commodities and they can provide some facility-based services. So as a country, we need to build a huge network of health posters, and we should also create a mechanism to ensure continuous supply of commodities. So creating that delivery mechanism, that supply chain, had also been designed. And the program has to also has to have, full community participation, and it has to be vetted by the community members. And the community needed also to have a say on who should be selected as a health extension worker. And we have to also look at the leadership and the monitoring and evaluation. So I will talk about how we have recruited, trained, deployed, and done these health extension workers. So when the program was initiated, the government had deliberately set these criteria. The first one is, all these health extension workers have to be females. For the fact that, we want our health extension workers to go house to house, spend much of their time doing house visits and discussing with women and with elderly in the community. And in our culture, it is going to be very difficult if you send a boy or a man to somebody else's house and ask them to talk to the women, without the presence of the husband. Since Ethiopia is, a predominantly agrarian economy, the men spends much of their time in the field, engaged in agricultural activities. So when health extension workers visit households, they usually interact with women who stay behind and take care of household responsibilities. So to have a better cultural acceptance, we decided that it should be females that should serve as health extension workers. And on top of that, these health extension workers will be, will serve as role models for young girls as well in the community. And these young girls, they can see the health extension workers who will relatively, be highly paid in rural Ethiopia, and they can aspire, to emulate the health extension workers and, spend much of their time in school. So it has also a women empowerment on the back of the program. And obviously they have to complete 10th grade, and they have to speak the same language, and they have to be from the same community. And if there are no candidates that fulfill these criteria, the candidate has to be selected from neighboring village and within the same district. And the health extension workers have to also volunteer to serve in the community for at least 3 years. So that was also part of the commitment. And we set a target of training 30,000 health extension workers, because we have 15,000 villages across the country, and a village roughly has 1,000 households. So we have one health extension worker for every 500 households. And we needed to construct these 15,000 health posters as well. So the health extension workers are basically, they are generalists at the community. They lead health programs. They are health educators at the community level. They do plan. They coordinate the activities of the community, and they train individual families and households. and they supervise the implementation of various health programs. So they have been tasked with a wide range of activities in the community. So the health extension workers, and the program is a comprehensive program. And when it was designed, it was believed that if they focus on these 16 different types of services, they would have an impact in improving the health situation in Ethiopia. So the first is, hygiene and sanitation. There are 7 packages that focuses on personal hygiene and, sanitation and so on. They focus on, they have 3 packages on disease prevention and control, malaria, TB, and HIV. There are 5 packages in family health, and they also learn about health education. So when health extension workers were initially deployed, this is a cycle that they have to do, and I'm sure most of you know Rogers' innovation diffusion model. So when the program was initiated, the health extension workers have been trained about this innovation diffusion. So in any community, there are these innovators who would welcome new innovations, new ideas, and are ready to, adopt those new behaviors and improve their health. So the health extension workers are encouraged to identify those innovators, and they go to those households, they teach them, and we designed what we call a model family training program. So these innovators have to pass through the model family training program, which basically requires for families, particularly women, to pass through a 96-hour training program, which spans over 4 months. And if the family adopts 75% of what they have learned and start implementing it, then they graduate as model families. And the graduation, before graduation, the district health office has to send supervisors and, ensure that the families have started, to practice those new things that they have learned. And in the criteria, things that will be checked is whether, kids are immunized from that household, whether the household has a latrine and are consistently using it, whether the family sleeps under mosquito nets, consistently. So there are a number of criteria, that were drawn from the 16 package, and if they fulfill 75% of the package, the family will be recognized as model, and the recognition is done, twice per year, and we organize a very big ceremony. The entire community will be invited, and the district administrator would be there, the village administrator would be there, and these model families are handed certificates, and they are told, that these are model families that are going to work with with the community and with the health extension workers to disseminate essential health message. So over the last 8 years, we have trained and deployed more than 38,000 health extension workers. 34,000 of them are in rural areas. We have 4,000 health extension workers in urban areas. And the urban health extension workers are, in fact, registered nurses, because the urban community has a better understanding of many things in the area of public health. So we thought it would be important to have registered nurses go through a 3 months training program on urban health extension, and they basically do the same type of activities that their rural counterparts do, but they are registered nurses. So the health extension workers empower caretakers, and they produce model families and communities. They have institutionalized and standardized the village healthcare delivery, which is linked to the primary health care. So in Ethiopia, the health extension workers are part of the health system. Whatever they do is captured through the health management information system. In fact, we have what we call a family folder. So every family in the country has its own folder, and their health situation and vital statistics are captured in that family folder. And those activities, those indicators are reported to the primary health center and aggregated there. It has increased access to basic health services, and it has reduced opportunity costs for families, and it has also enhanced participation of the community in the planning and implementation of health interventions at the community level. So since the introduction of the health extension program, we have seen a dramatic change in health service delivery. To give you some examples, I used contraceptive prevalence rate from the 3 DHSs. In 2000, it was around 8.1%. The modern contraceptives were about 6%. And when I was in medical school, we were told that it will be very difficult to change the behavior of the community. And for many decades, the CPR in Ethiopia was around 6 to 8%. But since the introduction of the health extension program, you can see that there is a significant change in the uptake of modern family planning methods in the country. So access was one of the reasons, and the fact that the health extension workers interact with mothers directly, it has also improved the uptake of services. If you look at antenatal care coverage, this is from our routine administrative report. It used to be around 50% in 2005, and it has reached 89% in 2011. So you can see that there is a significant improvement. However, we haven't seen a significant improvement in institutional delivery rates. Our plan was to have it, to make it 45% by 2011, but the performance is in fact 20%. So the health extension program hasn't really impacted the rate of institutional delivery rates, although antenatal care coverage has improved tremendously. This is PENTAS coverage, and there is also a significant improvement in PENTAS coverage and in minimizing the dropout rate. We have also seen a significant impact in reducing under 5 mortality. Ethiopia has achieved a 60% reduction in under 5 mortality over the last 2 decades. And if you take the 2 DHSs, 2005 and 2010, we have seen a 28% reduction. And much of the credit should go to the health extension program and how they provided services at the community level. We have now initiated a huge social mobilization effort, which we call it a Health Development Army. It's a new initiative, and we want to use this initiative to scale up best practices of the health extension program, with particular emphasis on improving reproductive, maternal, and newborn health. As you saw it in the previous slide, we haven't really improved the institutional delivery rate, so we really want to use this platform, the the Development Army platform, to improve uptake of critical maternal and newborn health services. So what we call the Health Development Army is a network of women who are drawn from model families. You know, over the last 8 years, the health extension workers have been training these women so that they become model families. So we believe that we have enough number of women that can influence, you know, their neighbors. So we are looking at mobilizing 3 million women across the country to serve as volunteers to influence their neighbors. You know, at the beginning of the health extension program, we designed, you know, 20 to 30 volunteers per village. But, you know, requesting these volunteers to go and visit, you know, 50 households, it's a full-time job, you know, in its own right. So they have a number of things to do, you know. They have to win their braids. So it is going to be difficult to ask, you know, volunteers without financially compensating them to go to 50 households and do a lot of activities. But it is easy to ask women to go to 5 households and, you know, interact with their neighbors. And if you look at the settlement pattern in rural Ethiopia, if you count 6 households, most of them are related either by marriage or by blood. So what we are asking these volunteers, these model women, is, you know, to effectively communicate with their relatives so that, you know, their relatives take up essential maternal and newborn health services. So we have started it 2 years ago, and in areas where the Health Development Army has become functional, we have already started to see a significant impact. There is one region in North Ethiopia called Tigray. So 2 years ago, the institutional delivery rate there was around 8%. And we are in the middle of our budget year, you know, this year. And the 6 months performance report showed us that the institutional delivery rate has reached 40%. So if they continue with the same rate, the institutional delivery rate will be 80%. And we have seen, you know, innovations that we never thought would happen, you know, in Tigray. I can give you 2 examples. One, you know, one of the barriers for women to prefer, you know, giving birth at home is, you know, deep-rooted cultural beliefs that are happening, you know, in most parts of the country. In fact, the last DHS showed us that 60% of women in Ethiopia believe that there is no need to go and deliver in health facilities unless you develop complications. So that's a deep-rooted belief. And in Tigray, you know, unless a mother, you know, takes something, a cultural meal, immediately after giving birth, you know, there is a belief that either the mother or the newborn will be possessed by evil spirit, and they might not be able to survive that experience. So the women knew this, and they said, why don't we go to the health center and prepare this cultural dish, it's porridge, and give to the mother immediately after giving birth. So they started to do that. They have started to contribute, various cereals that would be used to make the porridge, and they have assigned, members of the community to go and, prepare this porridge at a health facility. And that has significantly impacted it. And they have started to influence, elderly in the communities. They have started to have a dialogue with religious leaders. It is really a powerful way of, empowering women and making sure that they have control over what they do. So for this program to be successful, it needs high political commitment. And we have also made it a top political agenda in the country. And our Prime Minister convenes, a meeting with all the regional presidents and the regional health bureau heads, and obviously the Ministry of Health officials twice per year to review the progress in setting up a functional health development army. And every regional president, district administrator is also encouraged to do that. They only follow two indicators: institutional delivery rates and PMTCT coverage. Those are the two indicators that we haven't really performed very well. So what did we learn when we implement the health extension program? The first lesson is country ownership. The health extension program is a homegrown program. As you know, there has been various community-based health workers program across, the globe, but most of them were donor-driven, and most of them were specific to a single program. So in Ethiopia, we had, community workers for malaria, community workers for family planning or HIV, and so on. But since they were not owned by the government and by countries, as soon as the funding ends, those volunteer community health workers would go home and, stop doing what they do. Since the health extension program is designed and implemented by the government, it has really helped us to quickly go to scale and sustain it as well. And the government is paying regular salaries to these health extension workers. And that's, I believe, a sign of strong commitment. The second one is implementation at scale. When the program was designed, some of our donors were a bit nervous, and they wanted us to be cautious because, look, we are creating a new cadre of health workers, and they are going to be tasked for 16 different types of services. So initially, we were told to limit the number of packages and to pilot it in a certain geographic areas. But we know that those 16 different types of services are critical to have an impact on child survival, on maternal survival. So we decided to go and do it. And early on, as they started to see the changes in the performance of the health sector, many of our donors have become on board and started to support us. Setting ambitious targets is also important. This is something that we are known of in Ethiopia. And, in 2004, when we set a target of training 30,000 health extension workers in 5 years, many people were scared. I mean, they were saying, you don't have enough schools, you don't have enough tutors, you don't have the infrastructure to, and the resources to train 30,000 health extension workers. But at the end of the 5th year, we had trained 34,000 health extension workers. So I think being ambitious, there are a number of examples that we have successfully accomplished our ambitious targets. So setting ambitious targets is important, and continuously monitoring where you are in achieving those targets is also important. Task shifting does also work. The health extension workers, they provide injectable contraceptives. They provide, they do insert, single rod implants and so on. And task shifting is very important in a setting like ours, because we don't have enough number of doctors, and training doctors, takes a very long time. So our only option is to properly train and standardize the service delivery model through the health extension program, and task shift most of the responsibilities to these health extension workers and nurses and so on. So task shifting has also been something that we have really learned about. The use of model families and the recognition of families as models is also something that we have learned, and it has driven success in most places. So we have adopted, the model family concept and started to set criteria for model village, model districts, model zones, and so on, until the country becomes a model country in Africa. We have a number of challenges in implementing the health extension program. To mention few, the health extension program is a comprehensive program, a comprehensive service delivery program. But most of our donors and implementing partners are interested in a specific part of the health extension program. So we have observed that the health extension workers have been, called, invited, to various trainings, workshops, review meetings, and these review meetings were not coordinated, and it was difficult to coordinate because a partner who is working on HIV/AIDS, they want to really discuss about HIV/AIDS. They don't really look at the plan of the malaria counterpart, the hygiene and sanitation, and so on. So that has been a challenge. We are trying to integrate most of the training programs, review programs, and so on, but it's one of the challenges because the health extension workers spend a significant amount of their time attending trainings and review meetings. Attrition of health extension workers as the program matures, some of them want to leave the program, so that has also been a challenge. Providing continuous, reliable supervisory support to the health extension workers have also been difficult. We have observed that the health extension workers are motivated, and they are extremely committed to help their communities, because most of them are from the communities where they serve. But we have assigned a dedicated supervisor in a primary health center, for each health extension workers. We have 3,300 supervisors. Their job is, to supervise health extension workers. But the health extension workers haven't received, enough support because we don't really see commitment to the same level as the health extension workers. So we have been changing the model of supervisory support, and it hasn't really worked very well. Continuous supply of commodities is also a challenge because Ethiopia is a very big country. We don't have a well-developed infrastructure, so reaching every village across the country with all the essential commodities has been a challenge. So we have been observing, interruption in supply of commodities and so on. So we are trying to use technology to improve communication and ensure continuous supply of commodities. Infrastructure has been a challenge during the rainy season. Even if it is the same village, some villages are wide, and it will be difficult to access some households. And we have also some organizational challenge in providing support to the health extension program, and we are trying to reorganize them. So I think I have taken a lot of time to talk about it, so we can go into the question and answer.
No, stay here. So, outstanding presentation and a very innovative program that this is really the first I've been exposed to it. Questions for the minister? Yes.
Are you introducing cell phones into this program?
Yeah, these couple of days I was in New York talking about, technology and how we can use mHealth to improve, the service delivery through the health extension program. So we are looking at that. We have piloted, some approach, and we have now in the process of finalizing a roadmap where we are going to use cell phones at scale. 99% of our health extension workers have their own cell phones, so we are looking at using that as an opportunity to improve communication and improve service delivery.
I should apologize. I meant to say this at the very beginning. There's a conflicting seminar that's actually going on mHealth and the use of mobile phones in Bangladesh and the delivery of healthcare that's going on right now. It's what happens here all the time. You always get these competing lectures, but we just were at this 2-day meeting called Get Health, Global Education and Training in Health, and up at the United Nations, and it was superb on how we're trying to use technology and reach out to the different populations, and you can see where that would work quite interestingly with the program that the minister just described. Yes. Yeah.
Thank you. Could you comment on the family planning methods? I'm thinking, implants, IUDs, injections, female-male sterilization, pills, whatever. Which ones these health extension workers can do and which ones they have to refer? I understand you've had a little bit of demedicalization of contraception there that's been successful. Could you comment on that and how it might be useful in other African countries? Thank you.
The health extension workers are allowed to provide condoms, pills, injectables, and a single-rod implant. And they do refer for IUDs and sterilization. In fact, we introduced the single-rod implant in 2009, and they have successfully inserted 2 million implants over the last 3 years. The most popular method was injectables. For many, many years we thought, we wouldn't really have a good, coverage of long-acting methods, but when we task shifted the single-rod implant insertion through the health extension program, we saw that, the question was access. So that's why we are seeing, a significant shift into a single-rod implant. So my assumption is, had we the infrastructure to provide IUDs and sterilization, through the health extension program, we would definitely see an increase in the uptake of those services. So, yeah.
Yes.
You've had extraordinary success in recruiting these workers. And I was just curious, especially when you talked about model families and very often these extending to other members of the family. Do you have a vast difference in different parts of your very diverse country in the numbers of people that want these kinds of jobs? And do you have, therefore, problem distributing the services equally?
The health extension workers, by Ethiopian standards, are relatively highly paid, considering their level of training and so on. So, in areas where we have enough number of girls who have completed 10th grade, it was not difficult to recruit, candidates. But it has been very difficult to recruit candidates in areas where pastoralist communities live, for instance, because we don't have enough number of women going to school and so on. So it has been a challenge there, but in areas where the majority of the population resides, we were successful in recruiting these girls.
Do you have any strategies for these very difficult areas?
Yeah, we have designed a pastoralist health extension program. In fact, the pastoralist health extension workers, some of them are men, because we couldn't find girls who are literate enough to be a health extension worker. So in the pastoralist health extension workers, they have completed probably 4th grade or 5th grade, and they are not allowed to provide some of the essential services because they don't have the skills. So what we are trying to do is, to empower them to continue educating their communities. At the same time, they are also involved in the formal, school. So in some of the regions where these pastoralist communities live, for instance, there is one region called Afar. Some of the girls have already completed 8th grade, and they have started to provide some of the essential services. And we try to increase the support by, mobilizing what we call mobile health teams and, improving outreach support to the community. But it has been very expensive and very, difficult to really reach out to the entire pastoralist community. So there is a significant disparity in those places.
Yeah, picking up on that, do you see a difference between the urban setting and the rural setting in terms of the uptake of the health extension workers, the acceptance of the community? I would imagine it'd be more acceptable in the rural setting than the urban setting. Yeah. I was just wondering if you've been able to look at that.
Yeah, in urban areas, what has been the biggest challenge is, getting someone to talk to at home during the working hours.
Yeah.
Because in rural areas, the women will definitely stay behind, and you will have someone to talk to if you are a health extension worker. In urban areas, everybody is out of the house, and you go to individual houses, they are locked. So what we are trying to do is to encourage the urban health extension workers, to go during weekends and off the working hours and create, a relationship with families. And since most of the population in urban areas have cell phones, they can give a call and see whether, there is someone at home and so on. So it has been a bit difficult as well. But in the urban settings, we have included non-communicable disease into the package, and home-based HIV counseling and testing is also another package which is included in the urban health extension program. So there is, an incentive on the part